Are you checking joint mobility in your cervical examinations? Do you need to be? Are you even getting the information you think you are from these tests? And is this information actually helping you treat your patients? In this episode, we're gonna dive deep into the answers to those questions. So we're gonna start off, I'm gonna show you a lot of average clinicians do something that looks fairly similar to this. So first we look at upper cervical mobility, and then we're gonna check side glides through the cervical spine at each segment. Check how that mobility is doing. We're gonna go to the other side. Nothing's very stiff in here. And then we're gonna check passive range of motion in all directions. Side bending, rotation, get into some flexion, see how extension goes. And then I might even check combined motions. So let's look at what that information actually gives you, and is it helpful or is it not helpful? Most clinicians come from an education setting where they're learning an evaluation as a checkbox. So you go through subjective, you go through range of motion, you go through special tests, not so much regionalization, and then you check joint mobility, upper limb tension testing, and then you go through your muscle testing. But what can we do instead?
Yeah, we definitely don't want to do any tests just to check the box, because that's completely useless if you're just going through the motions. You have to know what you're looking for and why you're looking for it. You have to have clinical reasoning as to why you're doing the joint mobility, not just because it's a box that I should check. Because if you find something, how do you know that it's relevant, that you should address it? If somebody has raging radiculopathy from their mid-cervical spine and you find pain when you're doing side glides, right? Like, are you going to go do joint mobilizations to that area? Like, especially when we know that the hypermobility is what comes along with radicular symptoms in the mid-cervical spine, typically, right? Because that's the pattern of behavior for those joints. And if you find something that's painful, maybe feels restricted with that side glide, which I don't love that test, you know, maybe because of muscle guarding, you're going to go in there and potentially make things worse. So, one, ask yourself, why are you doing these tests? Don't do anything without having a reason. And you need to know what you're going to do with that information after the test. Is it relevant?
So equally importantly, if you get through a subjective evaluation and you already identify enough patterns and issues that you can start addressing and direct the evaluation the way that you want to go, and you don't need the information from the joint mobility assessment on day one, you don't have to check that box.
Yeah, absolutely. You should never be checking things just to feed the computer, right? Like, that's what a lot of people do. They're like, oh, there's all these check boxes in my computer that I have to put in my documentation system, so I'm going to check all of these things. That is a terrible way to run your examination, especially if somebody, one, it's not going to give you any information that is actually useful. There's no system to that at all, or logic, and it just causes a mass confusion. But if somebody comes in and they're super hot, they're super irritable, super acute, radicular, anything like that, it's okay to do almost or actually no testing, right? Like, nobody maybe told you that before. If somebody comes in and they're in a ton of pain, I'm going to do the least amount of testing possible, because that stuff is going to do nothing but cause an immense amount of pain for that person. Don't do it. I might just do a little bit of range of motion very gently of like, hey, so turn towards me. Like, I want you to move very slowly. Look that way. Okay, that's enough. Right, back towards me. Like, so you look that way. Okay, that's enough. Right, like just willing, like getting their willingness to move, and then doing alleviatory nice things because I understand the patterns of behavior. I got good information from the subjective, and I'm not going to do any of this stuff. So let's look at how you can assess joint mobility well. So upper cervical spine, I like to have people seated on a stool, and you would at this point have done the regionalization testing from a previous podcast to show, maybe I should look at the upper cervical spine. So this is just a giant monkey brain. It's actually a human upper cervical spine, but pretty cool. It's just a giant model. So when we're looking at moving the occiput, which doesn't get much motion, it only gets 1 to 3 degrees, depending on the textbook that you look at. We're going to be looking at the dorsal glide independently on the right and the left. So we have to stabilize C1. So we've got to get in front of, yes, people call them the articular pillars, but I still refer to them as the transverse processes. Whatever, judge me if you want to. Getting in front of the transverse process with your middle finger on one side and on the posterior arch of C1 on the opposite side, and stabilizing against rotation so it doesn't get pulled along. Caitlin's got her hair up. I'm going to stand on the side that I'm rotating towards. We find the mastoid process here. Move forward until you hit the jaw there, and then do a little DIP flexion in there. Don't go digging in there because it's a little tender, right? Mm-hmm. But that little bump that you might feel in there, if you've got good palpation skills, that's C1. So we want to try to dig in front of it. Thumb just goes right across the midline there, underneath the occiput on the other side, my side. I'm going to hold tightly here, little squeeze, not where it's painful. Elbows out to the sideline with my wrist, and all I'm going to do is just rotate towards me and hold there for a second. You'll notice there's not much motion. You could use combined motions here with the side bending and the rotation to see what happens if you get more or less and how they all feel. You're going to want to give a little overpressure and hold for a second to see if it, after a second, becomes a pain generator versus just seeing how it moves. So then the other side, you would walk around, but I'm going to have her turn around here for demonstration purposes. Same thing, right? And we're going to compare this side here to the other side. And there's another way that we can look at the mobility of it bilaterally on the table I'll show you in a minute. So that is the occiput, upper cervical joint mobility. Restricting motion below. We're looking to see, you can't see it here. Really, it's hard to tell for people that are new to this how much range of motion they have, but you can definitely feel that there's a firmer end feel. And then when we're looking at C1 rotation, we have to stabilize C2. Now C1, you get 45 degrees of rotation to the left and 45 to the right. So that's 90 degrees of rotation. That's literally half of your rotation from this single joint of C1 on C2. So what we're going to do is we're going to find C2, and then we're going to buddy up our fingers. We're going to bring our thumb and our fingers right to the tip of the spinous process, and then we're going to take up the soft tissue slack and squeeze it in to the spinous process to stabilize as we rotate from above. That looks like this, finding C2 here. Right, if you start right up on the occiput and you just come down, you feel a soft spot, then you feel a little bump in the middle. If you want to make sure you're there, one, I like to anchor my hands down so it doesn't move. But if you side bend, the alar ligaments there will create C2 rotation, so you'll feel the spinous process wiggle back and forth, and that's how you know you're there. So then you buddy your fingers up, grab the soft tissue, and pinch it all back in, right? Fingers are all buddied up here. It's not just one finger. So we're there. Pulling it in, and then my elbow stays in line with my wrist because now my forearm becomes a giant C2 spinous process, and I'm always rotating towards me. Go ahead and turn around. Let's look at this from the other angle. All right, so we're here. Sound effects are necessary, by the way. And we rotate, and we look and see, where does her nose go? That's the lever arm that we're looking at. Do we get about 45 degrees of rotation there? And what does it feel like at the end? You okay there? Mm-hmm. All right, so I'll do it a couple of times, holding, make sure I'm at the end range. If I'm at the end of the range when I let go, it'll rebound, it'll bounce a little bit. Versus if I'm here and I let go, there's no rebound. So if I get to the end range, I let it go, whoop, she bounces back a little bit, and that's how you know. So then we'll go around to the other side, and we'll compare this here. Right, a little rebound there. So we're gonna see, is it symmetrical? Is it 45? What does it feel like? Does it create pain? How's the end feel? And that is a good upper cervical joint mobility assessment. But let me show you another way to test the dorsal glide of the occiput. So for this, you're going to want to have them up all the way at the edge of the table. And whichever hand you want to use, whichever one you want to put down, right, you're going to have them scoot to that edge of the table so you can get your full forearm down. So since you guys are on that side, I'm going to have Caitlin scoot over to this side of the table. And then I want to get it where she's as close to me as possible, right about there, right? Because we need to be able to stabilize my hand on the table underneath her C1, but I don't want to be reaching for it. So if we find C2, right, that's the first bone that pokes out there. If you take your first MTP here, you put it on C2, and then you glide just off of it, just proximally, right in the soft spot right below the occiput. What my hand's going to look like is it's going to be thumb open here, not tucked in, because we need to make a nice firm surface, not a bag of carrots that collapses here. And it works out well because on this side, I've got pretty good range of motion versus this side, that's all my thumb does from a motorcycle accident. So this would actually push, for this side, would push into her face a little bit. Whereas on this side, I like to use it because it's not going to, so it's going to be more comfortable for her. So this hand goes underneath, forearms flat, finding C2, sliding just proximal to it, staggering my stance, making sure her head's in neutral, and then all I'm going to do is isometrically tighten my knife hand underneath her head and put my shoulder here on her forehead, and I'm just going to bend my knees to glide dorsally. You feel okay with that? Mm-hmm. All right, and that's another way you can assess that motion bilaterally. You could also have her nod down, right? Hold there, so you're a little bit of flexion, bring it to the end range, and then go ahead and relax. And then that would be more of how you would mobilize it. The joint mobility, I want it a little bit more neutral. But if you're a little unsure and you want to see, go ahead and nod down, right? So she flexes, you hold her there, she relaxes, and then you add a little bit of pressure there. You okay with that? Mm-hmm. Right, and then we just bounce. So that is a great way to check the upper cervical mobilities. Now, if we want to look at C2, 3, 4, 5, 6, a better option than the side glide test is the quick test. So a better alternative to the side glide test is going to be this quick test. The side glide is not quite as effective, right? Because you're just kind of grabbing and pushing, and it's like you're trying to down glide it with the line of force that you're getting, but it's not taking that joint and moving it around the axis of motion. And if you look at the actual cervical spine, like there is no, like, they don't move this way. That's not how it operates. They operate in an up glide, down glide fashion. So if I want to look at the mobility, I want to find C2, right? Spinous process, match my fingers up, flip to the radial border here, right? So we're going to go just outside of the spinous process, or right behind the facet joints, flip to the radial border, elbows are out, and I'm going to look, and I'm going to try to move around the axis of her nose here, because that's where the joint is, like right behind it there. So we're moving around the axis of the joint, and we're going to glide that side down there, and then we're going to add a little pressure here to create a pick on this side, and we're going to glide that side down. That's it, here to here. And what's great about this is I now have a long lever arm where I can see how much it moves. So I'm not looking at the joint, this little tiny thing there. I'm using the lever arm to the top of her head to see how much does it move. So on the left here, I have this visual representation of this is how much this joint downglides, right? Pretty good amount. And when I look at it from the right-hand side, we can see, that's a little bit different, right? Would you agree with that? Mm-hmm. We can feel that. It's probably a little tender to touch there versus this side, not so much. So that could be something that we could set up, right, if we wanted to, depending on her presentation here, and maybe do a little manip around. Go get some training on it, right? And then if we retest this, we look and see, now that moves a lot more. Now we can see that compared to that is pretty similar. And she's not jumping off the table when I palpate at it. So then you can go down to C3, and you can look and C4, C5, C6, C7. When you get down to C4 though, we need to start supporting the head and moving like a lollipop on a stick, right? So her neck is a stick, her head's the lollipop. You know, when you move the end of the lollipop, the whole thing moves. It doesn't bend in the middle. So if I'm trying to move C4, 2, 3, 4 here, and I'm moving everything above, I'm going to get a whole lot of extra motion that I don't need. So I want to get underneath, kind of cross my fingers and create the pick a little bit further down here, the fulcrum if you will, and then move the lollipop on the stick. Move the stick. And then I can continue down in that fashion. So I'm getting motion at that joint that I want. All right, if I'm down here at C7 and I'm trying to move this way or this way, and I'm getting all of this motion, that is giving me false information. We want to try to isolate motion at the joint as much as possible. Yeah, it takes practice, but you can have shitty techniques or you can practice and get good information.
If you found any of this helpful, you can learn more by clicking the link in our description box below and booking a call with us.
Yeah, in the call, it's gonna be a strategy session. We'll hop in, we'll talk about what's going on, what courses you might have done, how you treat, what systems and processes you follow. We're gonna find the gaps in your clinical game, and we're gonna help steer you in the right direction to make sure that you become the best clinician possible. Can't wait to talk to you.